All right, Eckhard, I think we're actually
Okay.
right on the time button now on all my different clocks. So if you're okay to start,
I'm okay to start.
we'll start. I will just introduce you briefly. I've had the great pleasure of working with Eckhard over the last 2 years on and off in his clinic in Hanover, where he mentors and works with many I guess academics of all walks of life, from musicians, psychologists, physiotherapists, doctors, all sorts of people. And I'm very much looking forward to him presenting some of his work with the dystonic musicians, so we can learn a lot from his 30 years of experience. Thank you so much, Eckhard.
Thank you so much, Bronwen. It's my great pleasure to be here, and hello to everybody. So I will give you a brief overview about our new ideas about therapy of focal dystonia. So I will focus on this. First, very briefly, phenomenology, then epidemiology, pathophysiology, also very briefly, but then we come to a more intense discussion of triggering factors, and Anna will also comment on this with the psychosocial triggering factors. And then I will go into the treatment options and go into prevention, which I think is the most important part of it. And then finally, the happy end is that we did the new review showing that 70% of our musicians suffering from focal dystonia remain in their profession, which is a very, very good news. So as you all know, musicians' dystonia is an isolated deterioration of motor control of skilled movements necessary for instrumental playing. And just for those who are not so familiar, two examples. So this is hand dystonia in the right index finger of a guitar player. And you can see an involuntary flexion of the guitar. Now it's very clear. And he has compensating movements in the thumb and in the middle finger. So the idea is very clear that you have an involuntary flexion, and the whole balance of muscular activation, of motor pattern activation, is somehow corrupted. And so it's not, we usually do not talk about finger dystonia, but it's a whole system which is not working properly. It's usually not accompanied by pain, and it is task specific at the instrument. In embouchure dystonia, it can affect the embouchure muscles, can affect the tongue and also the breathing muscles. And I see that you can hear the video. And here you see it's a tongue, overactivity of the tongue and the mentalis muscles as a compensation, and the tone production is not pure. So the attack is not very clear. It makes this pion. And this is, of course, it's very, very problematic for a professional musician here. So we have in hand dystonia, we have about 1 to 2% which are diagnosed, but probably there are much more musicians somehow having problems with their hand control. So I would guess about 5%. And this is much more common than any other hand dystonia, as for example, the Whiter's cramp, where we have an incidence or lifetime prevalence of less than 0.01%. Embouchure dystonia seems to be more frequent, and it's not so clear. It's also very much related to aging of the muscles of the whole apparatus, and it's also probably very much related to overuse. And so Anke Steinmetz, for instance, we did a review on almost all orchestras in Germany, and she found an incidence of 27% of embouchure dystonia episodes. So this is a little bit a different issue, and Bronwen has yesterday commented on this. Okay, now the point is, dystonia is not just a unity. There are very subtle forms. Like here, you see a very subtle, mild flexion tendency of the right middle finger when the student is playing wonderful scales. That's fine. When he's going to E flat major and he has to go into a black key for the middle finger, you see the problem. So this is just a C major. Compensating fingers are index finger and little finger. And now E flat major, and now and that's more problematic, but it's still very subtle. And of course, he can play on very high level. Here you see the typical dystonic posture. Now here it's much more problematic. In the next example here, you see the compensation of the wrist flexion, overflexion, and the overflexion of the left hand is fine. And finally, we have here some person who is really severely disabled. You see the thumb, index finger, very difficult. No pain. So it's a spectrum disorder. So we have this flow model of spectrum disorder saying that the less severe cases are called dynamic stereotype to avoid the traumatizing term focal dystonia. It's a kind of pre-dystonic syndrome and it has a better prognosis. And then we have, of course, persons who can just overcome this. Then in musicians dystonia, this is more severe, more permanent. It's more difficult to overcome it without therapeutic help. And if you have a dystonic cramp, that means in other activities, not only while playing the instrument, but also when writing or when eating or when combing, then it's very difficult to have a kind of spontaneous recovery. So this is just our idea that there is a kind of a spectrum of different forms of motor control problems. I will not go too much into the pathophysiology, but we know nowadays there are several loops in the brain which are important for motor control, but also for the limbic system and also for the anticipation of movements. So we have the cerebellum, we have the basal ganglia, we have the thalamus, and we have even changes in the brainstem and of course in the cortex in focal dystonia. So it's not one place in the brain, it's a kind of network disease, and it's an imbalance of these networks which probably cause this condition. And now I tell you why it's psychosomatic, because we have on one side, we have a lot of physiological problems which are might cause it. So for instance, dysfunctional technique, long practice sessions, overuse, and also trauma. But on the other side, we also have a lot of psychological issues which might trigger focal dystonia. And especially if you have an anxiety problem or perfectionist, dysfunctional perfectionist attitude, you might be at clearly higher risk of developing this. I'm sure that Anna will comment on this in the next speech. So what can we do? First of all, we have to inform the patients it's a dysfunction of the networks. As I told you, it's not degenerative. There are no nerve cells which are going to die. It's nothing really definite changing. It's a kind of imbalance of activation patterns. Then we can give perspective and hope. It's a learned disorder which can be unlearned. So this is the adaptive and maladaptive brain plasticity. And then, of course, you have to strengthen the chain spirits. The patients have to change their life, and then their life will change. And general prerequisites, of course, are motivation, self-care, self-awareness, curiosity, optimism, friends. And of course, we have as therapists, we have to address many, many negative emotions, feelings of guilt, feelings of shame, anger, frustration, self-devaluation, anxiety, and depression. So this is maybe the most important part of my work here, that I try to uplift the spirits of my patients here. And finally, there is a very important part that you relieve the whole thing and see the big picture. There is a life without being a performer. This is very important. Some of the patients are extremely focused on performing, and it's important that you widen their viewpoints. Okay, now we have a lot of training things, and there are ergonomic adaptation, and then there are these wonderful retraining methods. And Bronwen developed this off-instrument retraining. There is also on-instrument retraining. There are anticholinergic drugs which can be helpful. You can relieve the spasms and the cramping by temporarily weakening the muscles with Botox. And there are some electrophysiological stimulation methods, which in some patients have some limited efficiency. I do not do this now routinely because it seems not to be practical for most of the patients. We did one very nice study together with Floris van Vogt, where we investigated 53 pianists who underwent retraining, but of course they also underwent other therapies because they want to get cured as fast as possible. And then we had an evaluation after, in the average, 2 years, and we measured the behavior, the improvement in behavior, but also the improvement of subjective, let's say, emotions. So subjectively, the patient, so what you see here now, all the ones on the left side of the diagonal in the blue regions, those are all improved. So you see subjectively, they are wonderful, it's a wonderful success. However, when you measure on the method Hans Christian Jabusch invented, the scale analysis, when you measure the inter-onset interval standard deviation, the regularity of playing the scale, you see there are some who really improved, sorry, it's here on the right side of the diagonal, the improvements. There are some who really improved a lot, but there are some who did not improve a lot. And you see, the better they are, the smaller is the improvement. This is clear. This is a very common thing. So if you have a very severe dystonia, it's more likely that you improve. Okay, how can we now prevent it? And this is now very important. So we can, of course, prevent it by teaching our students. And that's what I do, what I did this morning, by the way. It's teaching our students to do warm-ups, to have a proper practice behavior, to have variable motor patterns when practicing, to have enough breaks, to have external focus, not too much focus on movements, but focus on the sound of the instrument. That's important. And then, of course, we can also prevent the muscular overload by informing the students and by giving them nice exercises also for their leisure sports activities and so on. Then, of course, we can, in the retraining, we can, when they feel that there's something not working very nicely, soon start to do slow motions, start to get awareness of your tensions, and start also to motivate for change management, and also induce variable training and reduce the compensation. That's very important. And I'm sure that also Bronwen has talked yesterday on this. There are medications, of course, which are very useful. So trihexyphenidyl is still the best and most useful drug. You have to dose it in a very, very low dosage, and then it's well tolerated. If you dose it too high in the beginning, you will have side effects. I also take frequently clonazepam. This is more problematic because it may produce, it's a benzodiazepine, it may produce a top form of addiction, so you have to monitor your patients extremely. But sometimes it's very, very helpful. And Botox injection can be very helpful in some patients who want a quick fix, but never do Botox alone. You have to guide them and you have to encourage them to do retraining. I'm very much in favor of retraining. For the psychological parts, of course, teach the students stress management, self-management, support them, give their confidence. And of course, in psychotherapy, if you have a problem, try to improve self-efficacy and also autonomy. And as medication, I usually take the highly selective serotonin reuptake inhibitors like escitalopram. And cognitive behavioral therapy is very important for the management of all the negative emotions. Okay, so now the happy end. We did one nice study. It's also already 6 years old with one of my psychology students. And we had just a questionnaire and we asked them whether they, how they were working, how it was going. And we found no differences in life satisfactions between the patients and the controls. And that was very interesting. So the patients, they were happy with their lives and 70% stayed in their profession. I think I have written it somewhere here, but it's not written here. So you have to believe me what I tell you, 70% stayed in their profession, of course. This was also a stay which was adapted. That means they were not playing exactly the same pieces. They had changes in the repertoire. They also say maybe focused a little bit more on teaching and less on giving concerts. And so, but they were happy and they were continuing making their money with being a musician, which is very important for the self-image and self-identity. Where to go? So we are presently evaluating the treatment methods, Kezia Droste and Julian Garni. Julian is a trumpet player who studies now medicine. And they are doing a big meta-analysis on all the therapies which are published in Musicians Dystonia. This is difficult because there are very many therapies. They are very problematic, how to say, methods and reports of the outcomes, but I think they both are able to come to a nice conclusion. And it seems, by the way, that retraining is probably the best treatment overall. We have also now a modeling of the triggering factors. That means with the kind of a model which part contributes anxiety, which part contributes perfectionism, which part contributes overuse. This is also Kezia who is doing this as a psychology student. We specify the roles of genes and deepen the analysis. So this is Johanna's poster. She will present tonight about this one. And of course, this is now my personal central thing. We have seen that many of our patients have adverse childhood events, parents emotionally cold, or abuse, or divorce of the parents, or psychological, psychic illness of parents. And so we have seen that this seems to be much more frequent in musicians suffering from dystonia as compared to healthy musicians. And Stine Alfeis is now working on this emotional triggering factor of early adverse childhood events in dystonia together with Attila Vorlich, who is also a medical student and a psychologist. And finally, Eduardo, who's presenting, I think, tonight also, this afternoon. Eduardo is working, he's a pianist and has a master in music, mind and brain. He's working on practice habits in dystonia because we are I'm absolutely sure that the dystonia patients may have some dysfunctional practice habit, and we have to detect them and we have to cure them. And then finally, we have to optimize the therapies. And this is what Andre, Daniel, Michael do all the time. So I think we are on a good way. And I think in generally, to come to the end, musicians dystonia has to be diagnosed by a neurologist. It's still a neurological disorder. And please, just many musicians now diagnose dystonia with their friends or themselves. Don't do it. There are so many other causes. It can be a kind of overuse crisis. It can be a cervical disc. It can be a nerve compression syndrome. It's not, if you have not enough control, it's not always dystonia. It's very important. Second, it's a spectrum disorder, that's clear. And there are various and variable networks in the brain involved, and it's a psychosomatic disease, and anxiety and overuse are important triggering factors. And there is retraining for long-term improvement. I think it's very efficient, and we have learned so much about retraining in the last 4 years. And so that I'm sure that we will even be even more optimizing this one. Botox can be a quick fix, and several drugs are efficient. And the prevention should address the healthy practice habits and, of course, support of the self-confidence to get these destructive emotions out of the brain, of the mind. And there's a good life with musicians dystonia. 70% remain in their profession. And I think with the big picture, If you are treating or working on musicians with dystonia, there are many ways you can contribute to a better world, but also musicians who are not more able to giving concerts or to teach, they have many other possibilities to contribute to a better world. That sounds a little bit like the Sunday sermon. I have a lot of people who have just worked together with me, and I really have to acknowledge them. And of course, Bronwen is here, very fresh, University of Sydney, but also my institute, Andre Lee, and also the former ones. So I think Hans Christian Jabusch, for instance, is here, and Alexander Schmidt, all former collaborators, and Peter Iltis is here, and Jens Fram and Dirk Voigt from Göttingen are wonderful, Shinichi. So you see, we have a whole network all over the world. And I thank you for your attention, and I'm happy for your questions. Thank you so much.
Thank you very much, Eckhart. As always, a wonderful talk. Our first question, I think, from Carolyn Palmer. If Carolyn, would you like to just ask your question live?
Thank you, Eckhart. That was a great overview of so much work.
Thank you, Carolyn.
I'm really interested in these different contributing factors, the psychosomatic and the neuromuscular. And we know that, at least with piano performance, the higher conceptual pattern that you in a really well-learned piece can transfer between hands. So have you ever seen cases where if the dystonia is limited to the right hand and the person tries to play that same pattern with the left hand, do they develop, are they more likely to develop the dystonia in the left hand, or is it completely different because of the different mapping of finger muscles?
They are more likely to develop, in the other hand, dystonia, unfortunately. So this we have to, this is by Caroline, this is a very good question. This is, for instance, also why we are very, very careful when we consider in young dystonia guitar players to switch the hands, for example, go from there to there, or to switch in flute players from the normal right-handed flute to the left-handed. It's very dangerous. You have to really monitor them, that they have usual, very, very clever practice schedules, and they have to avoid what I say, this kind of zwanghaft, constrained motor habits. They have to avoid them. This is really poison for the motor system, constrained motor habits.
Okay,
thank you. Alvaro, do you want to ask your question, or do you want me to read it out?
Thank you. I can ask.
Yes.
Thank you for the presentation. What could be the main function of anxiety and stress in the development of focal dystonia? Do they motivate over practice and fatigue?
Excellent question. There is a twofold. There's a direct biological part. So if you have early childhood traumatization, you develop less stress tolerance, and you will develop a higher muscle tone. This is very difficult to prove, and it's very difficult to investigate, but probably most people who have this kind of reduced stress tolerance, they have a higher muscular tone, and the higher muscular tone puts more load on this motor behavior. And so they are at higher risk. The second part is, of course, that they develop this kind of anxiety disorders and start to probe all the time whether they are still able to do the function, to play the piece, for instance. And they have this kind of compulsive practice behavior, which is, as I said to Caroline, which is poison for the motor system. So there's a twofold part. There's one psychological and one direct, I would say, stress tolerance neurobiological mechanism.
Thank you. May I ask just a quick follow-up question? You said that only a neurologist can diagnose it, which I think is good to know, but how aware are they of this condition?
Yeah, that's another point. You are right. There are some neurologists who have no idea of focal dystonia. You are right. Yeah, the point is, I do in Germany since 25 years, I do a yearly kind of course for the neurologist on musicians dystonia. So in Germany, we have a good situation. I think all neurologists and hand surgeons know about focal dystonia. I know that's not in all countries like this. But the point is that, for instance, many neurological disorders start like dystonia, for instance, beginning of Parkinson's disease. And it terrible if you put a Parkinson patient instead on Madopar, dopamine. If you put them on Botox or something like this, it's really something. And so I think it should really be seen by a neurologist who is informed. So what I really try since 25 years also internationally to inform my colleagues in the other countries about the conditions. It's a very rare condition, and I know, of course, many of the neurologists, let's say in smaller places, they see maybe 1 or 2 during their life, but they need to know about this.
Yeah, and I think I just went to a neurologist's meeting at Westmead last week with your friend Victor Fung, Eckhart, yeah. So Eckhart has come to Westmead and guided them, like over to Sydney and guided them, and they now have a big group meeting so they can help each other. I think neurologists are, it's very good if they have a group where they can talk together with this. Susie, you wanted to ask a question to Eckhart, Susie Wiseman? Susie, are you unmuted? Just there you go. Not quite unmuted yet, Susie.
Oh, okay, sorry about that.
Hi, Susan. Hello.
Your presentation. Hello. I had a question. You stressed the importance of prevention and, of course, looking at what we can do at the younger ages of training. And I wonder if you have any thoughts or advice about what we in the teaching profession and those of us who are responsible for teaching young musicians can do to make that those sort of changes at our level.
Yes, absolutely good question. So prevention starts with the first lesson at the instrument. It should be teach the practice strategies. It's very important. Teach external focus. That means focus on the auditory events. That's very important. Support the students. Start with the right instruments. For instance, in flute players, if you are an 11 years boy, as I was, and I played the flute and my hand was stretched like this, and I had a dysfunctional C key, and I pressed with my little finger a lot. This is not the good start. Try to have very good instruments and try really to teach the students from the very beginning self-management. That means they should stop when they are tired. They should, even though they are so motivated, they should learn to feel how they how their body reacts to the mental and to the physical load of playing instrument. And then of course teach them enthusiasm with music. That's the most important. And avoid perfectionist behaviors. That's another point.
Eckhart, you have one more question before we move on to Anna. So Anna Paula, do you want to ask the question, or I can ask you asking about whether these kind of patients need to implement relaxation techniques?
Yeah.
Like
most of them need to, I would say they need relaxation techniques in terms that they can monitor their own tensions. So the point is more tension control. Pure relaxation is not enough. It should be control of tensions which are dysfunctional. And you have to learn this. This is something which is excellently learned in Alexander technique, Feldenkrais techniques, the usual body techniques. So the tension management. Relaxation itself is just a short-term fix. It's not really the one thing you need, because when you play, you cannot be relaxed, unfortunately. I mean, you can relax in many muscles, but in some muscles, you have to be very nice on tone.
Wonderful. Does anyone have any other questions before we go on to Anna? Any last call for questions? Wonderful. I think you've given everyone a lot of things to think about, and a wonderful presentation as always, Professor Altenmüller.
Thank you, Bronwen. And thank you all for listening and for your questions. And I'm very happy to see Caroline again. Wonderful.
All right. Thank you very, very much. Anna, would you like to get your presentation up on screen now?
Yes, thank you. Here we go. So welcome everyone. First of all, it's like an exceptional honor to speak after Professor Altenmüller. Slightly scary also. My name is Detari and I'm a flutist. I have my first master degrees from the Liszt Academy from Budapest, Hungary, and I also did a master in science in performance science at the Royal College of Music. And currently I'm a PhD student at the University of York under the supervision of Dr. Ackermann. And my research looks primarily at musicians' vocal dystonia. And I'm interested in the psychosocial and psychological risk factors which might play a part in the onset. So a lot has been said about musicians' vocal dystonia in the past like half an hour, but for those who are just joining us, I'm just going to give a very brief background. Musicians' vocal dystonia is a task-specific neurological movement disorder affecting 1 to 2% of highly skilled musicians. And there is an estimated dark number of 5% people who don't get diagnosed, just as Professor Altenmüller mentioned. And there are certain instrument groups which are more at risk. Again, I'm going to repeat this number of 27% among brass players who potentially can be affected by the condition. It impairs the fine motor movement when playing an instrument. It can manifest itself in like cramps, spasm, overactivation, certain muscles, weakness in others. So it's a complex pattern most of the time. And neurologically speaking, it's an inhibition deficit or maladaptive plasticity in different parts of the brain, different networks of the brain. But it's not really clear what actually triggers really these changes, not yet anyway. And full recovery is quite rare, as also been mentioned before. So the traditional approach with understanding and treating the condition was strictly medical for quite a long time and focused mainly on the organic factors such as genetic predisposition and neural changes in the brain. And the treatment strategies aligned with this kind of thing, looking at either targeting the brain via oral medications or brain stimulations or directly the symptoms, by trying to block the unintended movements with botulinum toxin injections or attempting to retrain the movements with various behavioral therapies. The common denominator between these is that the focus is usually on the motor symptom exclusively. However, in more recent research, we note that there are several non-organic factors which might influence the onset. There is an emerging body of research about psychological and psychosocial factors, including several articles already mentioned, which indicates that musicians' vocal dystonia sufferers have significantly higher rates of perfectionism, anxiety, phobias. There are descriptions of traumatic experiences preceding the onset, emerging evidence that the sufferers might have more ACEs, advanced childhood experiences as well. Moreover, Stadnicka and her colleagues proposed a new framework for understanding the condition from a neuroscientific viewpoint, which lists cognitive and emotional factors, modifying the movement skills, and the discrepancies between the motor skills and the task requirements as risk factors. These factors are generally under-researched, anecdotal, theoretical, and we don't really know a lot about the prevalence and how they impact the condition. Therefore, more research is needed to identify these factors, how they manifest as non-motor symptoms, and how they influence the rehabilitation. So in this slide, you can see a recent and frequently used model of musicians' vocal dystonia by Professor Altenmüller and his colleagues, which acknowledges the role of the instrumental technique, overuse, cognitive and emotional processes, and psychological traits. Obviously, some individuals are genetically predisposed and have some innate characteristics that might put them at risk. However, we know that the psychosocial environment has a role in shaping some of these characteristics. Some even argue that some mental disorders, such as anxiety disorder, which is frequently mentioned in relation to musicians' vocal dystonia, should be understood as a learned response to adverse experiences arising from the environment. Also, the quality of the instrumental technique, which is listed as a sensory motor triggering factor, is definitely not developing in a vacuum, but as a result of education, personal experiences, and social interactions. Therefore, we were interested not only in the existing and currently measurable psychological traits, but sort of the trajectory of their development. How some personal experiences and psychosocial factors shape these individuals who later got diagnosed with musicians' vocal dystonia. In order to form a better idea, we ran a set of studies, starting with a grounded theory interview study with the goal of identifying topics and themes emerging directly from the personal experiences of the sufferers. These were sort of like life story interviews, which invited the participants to speak freely about their relationship with their instrument and their musical careers. This study resulted in a very rich qualitative and subjective personal data. In the second study, we interviewed practitioners who frequently treat the condition, using the themes emerging from the first study to inform the interview schedule. The 14 participants in this study met and treated a large number of participants with musicians' vocal dystonia. Together, they interacted with more than 1,500 sufferers, producing a very large indirect sample. They were also asked to describe similarities between the patient's stories and personalities, and to verify or reject the topics which emerged from the first study. The third study, which I would like to talk more about today in fine detail today, is a generalizing survey study, which attempted to quantify some of these findings and compare musicians with dystonia with the healthy musician population. So the personal narrative of both the sufferers and the practitioners describing their experiences and their observations produced a very rich qualitative data with multiple themes. During the process of creating the final survey, we focused on 4 main points. We tried to find topics which were strongly supported by both the interview studies. We were trying to focus on new topics which were no previous research was available on. We were looking for topics which were supported anecdotally or theoretically by previous literature, and whenever we could, we tried to use validated scales in this process. So on this slide, you can see a short list of the chosen topics and the scales. The main themes emerging from the interview studies were, on the left, experiences with music education, mistake rumination, trauma and change, perfectionism, reinvestment, and insomnia. Musicians with dystonia were asked to fill out a newly constructed dystonia severity scale. I'm going to talk a lot more about this later, and answered questions about their received treatment strategies. Musicians without dystonia filled out the musculoskeletal pain intensity and interference questionnaire. This data was collected to find possible links between performance-related pain and other topics in the questionnaire, but due to the length and the focus of this presentation, we cannot delve into this analysis right now. Both groups filled out a student-instructor relationship inventory, self-constructed questions about the received music education, and the mistake rumination scale. These scales are naturally retrospective, therefore the comparison between the groups resulted in no problems. However, since we specifically were interested in the perfectionism, movement reinvestment, and insomnia of musicians' vocal dystonia sufferers prior to the onset, we could not compare these measurements with the healthy population because of the various timelines of the participants. Therefore, we decided to see if there are any relationship between the severity of the symptoms and these variables. So there are 2 main analyses done in this study. One of them is a comparison between healthy and healthy and dystonic samples, and the other one is done within the dystonic population. We collected 175 responses for musicians with and without dystonia. For the first analysis, we created a matching data set for the comparison. So we paired the participants based on gender, age, and instrument type, which led to a subset to 88 musicians. On the right, you can see the instrument ratio of this subset. It's quite hard to see, but basically wind, brass, strings, piano, percussion, and guitar were the instrument groups we placed these participants in. Since we used a self-constructed scale about experiences with the received music education, themes and ideas which frequently came up in the interviews, an exploratory factor analysis followed by a confirmatory factor analysis was necessary. Originally, we constructed 20 items, which we randomly selected half of them and reversed them to avoid participant bias. 14 of these items loaded well and confirmed the presence of 4 underlying factors. Unfavorable teaching style, which included authoritative teaching, high demands and prescribed perfectionism, On healthy body mechanics, these items dealt with the quality of information about a healthy technique and lack of concerns over performance-related pain or injury. Technique-focused teaching, items cluster around extreme focus on the technical production of the sound and lack of instruction in musicality or expressivity. And early success, which related to playing demanding materials quite early on and rapid advancement on the instrument. This last one is an interesting one. In the interviews, participants reported being the talented one, being ahead of their peers and accessing playing opportunities which were out of the reach of most of their peers. So it might be possible that they did too much too soon. And since Sadnitska's model of musicians' vocal dystonia lists discrepancies between motor skills and task requirements as a risk factor, this topic was deemed worthy of further investigation. So we first did just an initial exploration of the data, conducted simple t-tests between the groups, and identified differences. And we found significant differences in 4 of these variables. Musicians with dystonia reported rapid advancement on their instruments at the beginning of their studies and more mistake rumination. Also, their educators were less concerned about healthy playing technique and posture or playing-related discomfort or injury, and had a more controlling, perfectionistic, and teacher-centered teaching style. On the next slide, sorry, I skipped one. On the next slide, I have some honorable mentions which did not reach the statistical significance, but show the hypothesized tendencies. So this is the student-instructor relationship scale items. Healthy musicians reported to be more connected to their teachers, as seen on the left, and musicians with vocal dystonia felt more anxiety around them, as seen on the right. This tendency shows that the topic is worthy of further investigation, even though we couldn't show statistical significance in this particular sample. To build a comprehensive model of using all these variables, we conducted a logistic regression using the presence of musicians' vocal dystonia as a dependent variable. 3 of the previously mentioned factors predicted the presence of musicians' vocal dystonia adequately. The model indicates a significant positive association between performance mistake rumination, early performance success, lack of instruction about body mechanics during music education, and being affected by musicians' vocal dystonia. And this model classified 68% of the cases correctly. Before I move on to the second big part of the analysis, I would like to include some details about the trauma scales. One of these, the trauma history screen, is a validated scale to measure 14 different kinds of traumatic experiences. The other was a self-constructed one, mostly focusing on not necessarily negative but stress-inducing events, which included items frequently mentioned in the interviews as triggers for the condition, such as change of workplace or change of instrument. But there were also traumatic ones, such as death of a close relative or getting a divorce. We were not able to show any significant differences between the samples, in spite of the fact that preceding traumatic events or significant change had been mentioned in the literature, had been reported in all the interviews we conducted, and the recent literature shows that musicians with vocal dystonia report more ACEs, advanced childhood experiences. The possible reasons for this might be that maybe the chosen tool, the trauma history screen, is a quite general one, including events like natural disasters and car accidents as well. Also, in the second self-constructed scale, dystonic musicians were asked to report about the year prior to the onset, while healthy participants were asked to report about their previous year, which was in the middle of a pandemic. This obviously triggered many unfavorable changes in the healthy participants' life, basically rendering this scale unusable. Moreover, musicians in general report more trauma than the average population, and traumatic events affect people very differently depending on their personality, social support system, and so on. So maybe measuring only whether an event happened or did not happen doesn't provide enough information. We can certainly say that although here we could not show any main significant difference, the topic is definitely worth more investigations. So for the second analysis, we used the whole dystonic sample, which included 125 participants, 49 females and 76 males. Just an interesting note on the gender ratio, it is roughly 2 to 3, which differs from the usually reported ratios, which range between 1 to 2 and 1 to 6. It is possible that our sampling methods, which included a lot engagement with social media platforms, websites dedicated to musicians' health, sending the call for participants to private practitioners to pass it on to their clients, and all sorts of different other methods, reach somehow a more diverse sample. You can see the instrument distribution on the right. So most of the participants were playing brass instruments, piano and guitar, with fewer string, wind, and percussion players. So in order to look at the correlations, I first have to introduce this scale we constructed, the newly constructed dystonia severity scale. So basically it follows up in all on previously used dystonia severity scales. It adds to capture the self-reported difficulty with the instrumental playing, but in a slightly more detailed way than previous ones. We asked the participants to rate the difficulty they were having due to the symptoms in different aspects in the musical output. The original list contained 14 items, from which 11 loaded well and formed 3 distinct categories. These were dubbed as melodic, difficulty playing slowly, legato, quietly, and sustained the playing for longer stretches of time; vigorous, which included difficulty playing loud, staccato, changing rhythms and playing with no warm-up; and technical, difficulty playing scales, fast or repetitive rhythms. We also calculated an overall score for the impact of dystonia on the playing and used that as well in the further analysis.
And just to let you know, you've got 4 minutes about left.
Okay, I have 2 more slides, so we'll be fine.
Perfect.
So the results from, we used these scores when we ran these correlations and found a significant relationship between the self-reported difficulties and perfectionism. To measure perfectionism, we used a modified version of the multidimensional perfectionism scale sport version, which measures the concept in 4 different subscales: personal standards, concern over mistakes, perceived parental pressure, and perceived coach pressure, which was changed to teacher to align with the context. When examining these subscales and the perceived difficulty with the playing, we found that the most important contributor to the significant result was the subscale perceived teacher pressure, which further underlines the importance to conduct further research in the psychosocial educational environment of musicians with musicians' vocal dystonia. The most obvious limitation of this study is that it uses self-constructed and not previously not tested scales. We had to proceed with this method because of the lack of scales measuring the constructs highlighted in the interviews. Also, musicians with vocal dystonia were asked to recall personal ideas, feelings, and psychological states prior to the onset. This was necessary because we were interested in the contributing factors, but obviously it might not be fully reliable, it relies on memory, and it carries the possible personal bias. Also, there might be some other underlying constructs which are contributing to all of these differences. Nevertheless, this exploratory study highlights the importance of researching not only the currently present traits in sufferers, but also to look at the developmental trajectories of these. So in conclusion, the way the instrument was learned, the context, the content and quality of the received teaching might have an influence on developing musicians' vocal dystonia. The people's life who are struggling with the condition have to be viewed as a complex and continuously evolving system, which is influenced by the environment. This can help us to clarify the pathophysiology of the condition even more and can inform preventative strategies. We also learned that certain psychological factors might worsen the symptoms, which indicates that if non-motor symptoms were therapeutic targets alongside the motor symptoms, it could potentially enhance current treatment strategies. This is only an early exploration, a first step towards these goals. We need more refined methodological tools to assess these various contributing factors and more research to explore how these might impact the individual musicians. So I'm going to stop right here. Thank you so much for listening, and I'm very happy to answer any questions you might have.
Thank you, Anna. That was a very interesting talk. I think followed on very nicely from Professor Altenmüller. I think you can be quite happy with yourself.
Thank you.
Does anyone have a particular question? Susie, this answers a little bit of what you were talking about before with perhaps the role of the teacher, or perhaps what we don't want to have from the teacher, the kind of stricter attitudes, I guess you're talking about, Anna.
Yes, if I can just jump in there, I was really interested in what you had to say, and of course, I think what I find most interesting is that both of these presentations touch on something I think that's really important, and that's how the psychological, or what you describe as the psychosocial experience of young learners, and how that becomes not just a psychological matter, but then can become later certainly something that is most definitely a physical disability that or injury that affects musicians, and it underscores even more the sense of responsibility that I think we teachers must have, and the importance of educating teachers and finding ways to improve the teaching, so that the level of prevention that Eckhart was talking about can actually take place.
Yes, I actually do agree. Sorry, I just thank you for saying that. I do agree so much.
Thank you. Eckhart has raised his hand, so would you like to?
Oh, congratulations, Anna. It's great work. I think it's exactly the right step you follow, and it's also very nice. I would like to put you with Eduardo in contact, because he's interested in practice habits, which of course are mainly have their sources in the teacher-student relationships.
Absolutely.
I think it's great. I wonder, do you know more about the respondents in your online questionnaire? Do you know more about the musicians who responded to your questionnaires? Are they classical musicians? Do you know something about their age and so on?
Yeah, the majority is classical. I think up to 90-something%.
Okay.
We also included questions I don't remember the age ratio by heart, but we measured the age at onset and the current age as well.
Okay.
So there were some respondents who were 60, 70 years old, but they had the onset at 28 or 30. And this whole problem with the timelines and the comparison, this is where it really came from. And also we also include the question whether someone was diagnosed by a neurologist or not. And I'm planning to run some subsequent analysis on the sample only on those who actually were diagnosed by a neurologist. Because we had a couple of it was a multiple choice question, including diagnosed by a neurologist, diagnosed by fellow musician, diagnosed by other sufferer, just to see how we learn that we have focal dystonia and how accurate that piece of information is. So I'm still not done with the analysis, and I actually had a couple of questions included practice habits as well, but I haven't really gotten to that point analyzing that yet. So it would be really lovely to talk to Eduardo, he said.
Yeah, thank you.
I have a question here from Amandine saying, how do you think you could make music teachers more aware about the consequences of their teaching on their students who perhaps would go on? I guess they're saying the learners who have been diagnosed with dystonia. Perhaps it's not, maybe you can't tell them they've caused it. I'm not sure exactly how the question's aimed at, but perhaps how do you make teachers more aware about the consequences of their pedagogy?
I was actually planning to run a set of events for music teachers, particularly here in the UK, just to make them aware of this impact and maybe talk a little bit about musicians' dystonia and, what sort of things can lead towards that road. And if it's not musicians' dystonia, very similar behaviors can lead to performance-related pain and injury, which we also know is very, very prevalent in this population. So I was actually planning to do that. And also musicians' dystonia, and I fear there is it's a taboo. We don't talk about it. People who have it don't. It's getting slowly better, but I also think that many people need to get introduced to the concept. I meet many musicians, especially back home in Hungary, who still treat this thing like it was contagious, like if you hear about it, you catch it, sort of thing. So I think spreading the information in workshops, sandpit events, any way possible would be very, very beneficial.
Okay. Hans Christian, would you like to ask something?
Yeah, first of all, thank you very much, Anna, for your very nice talk and for this exciting project and these results. And there's just one detail I'm interested in. You talked about the early performance success, and of course that's in line with that's a finding that I didn't hear before, and that's in line with the other findings according to which the good ones, the good musicians, those who later work as soloists, are affected. And there is another former finding from Alexander Schmidt. And he showed that musicians with dystonia usually started to play their instrument later than the others. So age 10 in contrast to the others who started in the average age 7. So I would like to ask, do you have information, maybe you said that and I missed it, at which time was this early performance success?
So basically they were... Yeah, so basically we were asked questions when you started playing the instrument, so it wasn't specified. We do have the data for how long they've been playing the instrument, because I wanted to look at for after how many years of playing did they reach the dystonia. So it's possible to compute. I haven't done that yet. But I think the two things link, because in my interview studies, I also found that many of these people started slightly later in life or started with another instrument and swapped to the primary instrument on which they later became dystonic later in life. And I think it's like there is an overlap between these two things, because if you're very talented and you're age 10 and you just start playing the instrument and all your peers are much more, advanced than you, then you feel pressured to play more advanced materials to advance more rapidly as well. So there might be an overlap between these two things. And I think it all really comes down to play more advanced materials than you're actually capable of, or what your system is actually capable of dealing with, or really learning the basics very accurately and like really deeply. I had a participant who like age 9, started playing age 9 and 11. He won an international competition. Mm-hmm. So we are talking of that level of pressure and advancement. But yeah, I can do that, look up that data, the exact age, and I can report it later in a paper if it gets published. Yes.
Thank you very much. Mm-hmm.
Does anyone have any other questions for Anna? I am also interested in this idea. I think we have to be a little careful. I would be interested in both Professor Altenmüller and Professor Jabusch's ideas on this too, but with having focal dystonia awareness, I think we have to be a little bit careful that we don't, if you like, as you said, get this kind of idea that everyone becomes infected with it. It's quite at the moment a little bit over self-diagnosed. Would be my impression. I'm not sure what you think.
I absolutely agree. We have to be very careful, because that's why we invented this term of dynamic stereotype, to just release a little bit of the pressure. I think in the beginning, overuse and anxiety can have exactly the same phenotype as real focal dystonia, which is, for instance, genetically inherited. I have also to say that the high amount of brass instrumentalists, embouchure dystonia, I think those, for instance, tongue stopper is very frequently a focal anxiety disorder. This is just an anxiety disorder, and it's very important to somehow soothe the patients not suffering from this difficult to treat condition, focal dystonia.
One other question just from Tiago about the role of biomechanical knowledge. I guess this is what you say, like balancing this internal focus with external focus, but he's asked particularly about like comparing sports science to music science, like how much more biomechanics should be in there. Would it make a difference with this kind of problem?
I'm pretty sure it would, because yeah, I'm pretty sure it would, because sometimes even teachers are not really aware how the body should look like or how the body should be used when playing an instrument. And as Eckhart mentioned, then we teach instruments to children like whose body is not yet prepared for the size of that instrument or the heaviness of that key. But also like just being aware of a correct posture or correct breathing, not allowing a student to develop like an extreme embouchure, for example. I taught flute for over 15 years, and then sometimes I got students from other teachers, and then their embouchure looked like something horrible, and it was already practiced in. And these are the kind of things you have to like establish at the beginning, just like how you sit, how you hold your wrist at the piano in order not to injure yourself. So I think it would be very, very important to have more knowledge in the general like music education, like primary school level, teachers who teaches like this generation to be more, you know, aware of these things, and not just like how does that piece sound, or is it in tempo, or did you press the right key? Is this an F sharp or not?
Thank you very much. I should get on to Tristan now. Thank you very much, Anna.
Thank you so much.
Okay, good. Tristan, would you like to introduce yourself and then put up your presentation?
Well, thank you, Bronwen. So my name is Tristan. I'm a postdoctoral fellow working in the Faculty of Music at the University of Toronto, and I work under the direction of Professor Michael Tout. And this is my very first ISPS. I'm very excited to share my presentation with you. My primary research focus is in basic sensory motor control in music. So my main focus is how we can optimize motor learning in music. And then I take and I apply what we learn in that particular field towards rehabilitation in chronic stroke. So how can we teach people to relearn movements with their injured limbs? So with that introduction, I'll get started. Hello. Today I'll be discussing a bit of a different topic in the arts and health. In particular, I'll share some exciting findings regarding how the rhythmicity of music can be leveraged to retrain the injured brain in chronic stroke patients. Stroke is a global health concern, and with over 80 million survivors worldwide, stroke is a leading cause of disability. As millions of individuals live longer with functional health loss, the economic burden due to post-stroke care continues to rise. Stroke creates such a burden on society due to the widespread motor deficits associated with chronic stroke conditions. Chronic stroke is a disabling condition affecting the individual, their family, and society at large. The most common post-stroke dysfunction is motor impairment, involving loss or restriction of functional motor control. Major obstacles to functional recovery include paralysis or paresis and loss of coordination in the upper limbs, as well as a reduction in muscle length and increased muscle stiffness. Measures of activity and participation in chronic stroke individuals revealed that 39% experienced limitations in self-care activities, while 54% reported impaired abilities to perform activities of daily living, including meal preparation, housework, and the use of a telephone. If a functional threshold of recovery is not reached, the affected individual may resort to compensatory additional movements or learn non-use. This behavior in turn may diminish the sense of well-being and limit social participation. Physical therapy interventions must therefore be developed to improve volitional motor control that are not only cheap and accessible, but most importantly, effective. Although stroke is debilitating, spontaneous recovery is known to occur in the first few weeks following stroke, and engaging in physical therapy-based rehabilitation is thought to modulate this recovery. Because modification of movement ability appears to be use-dependent, it's critical for persons in the chronic stage, when recovery is often thought to have plateaued, to continue to engage in innovative forms of rehabilitation. By engaging a multisensory motor network linking diverse brain regions, music exerts multimodal effects on individuals, which may be used for therapeutic purposes in neurorehabilitation. Neurologic music therapy is a research-based approach leveraging the rhythmicity of music in rehabilitation with a number of specifically designed techniques. The NMT technique employed in this study is known as therapeutic instrumental music playing, which was developed from the rhythmic auditory stimulation method of NMT. RAS provides predictable anticipatory rhythmic timing cues, similar to a metronome, that can entrain movements and improve motor control in stroke and Parkinson's disease. Shown on the right side of this slide is a velocity profile of the wrist joint when patients who have suffered from a stroke engage in a reaching movement.
As we can see on the right side, when no rhythm is provided, there are many peaks and valleys in the velocity profile. In contrast, when the rhythm was provided, we get that classical bell-shaped velocity curve common in typical upper limb reaches. The present study paired rhythmic auditory stimulation with therapeutic instrumental music playing, wherein digital and acoustic instruments were used as movement endpoints for paretic limb reaching. A novel assessment of motor relearning was applied in the present investigation. Due to the wave-like form of acceleration traces inherent in upper limb movements, measures of acceleration can be easily obtained and quantified. Moreover, based on the oscillation frequency decomposition method developed by Joseph Fourier in the 19th century, it is possible to extract critical sensory motor processes from acceleration traces of voluntary reaching movements. More specifically, the relative contribution from different oscillation frequencies within an acceleration signal can be extracted via what is known as normalized power spectral density function, shown here on this slide. In these frequency domain representations, increases in frequency power localized to peaks in the power spectrum represent greater average acceleration at specific rates. This is illustrated in these two figures, which was work done by one of our collaborators. Peak power is shown on the y-axis and frequency is on the x-axis. The experiments had participants reach in two conditions, one in which full vision of the environment was provided, whereas in the alternate condition, no vision of the environment was provided during this reaching action. As is clearly shown, peak power is greater in the full vision condition relative to the no vision condition, with peak power being localized within the 4 to 7 Hertz range. The greater peak power values found in the full vision compared to the no vision condition further emphasize that increases in peak power result from purposeful, feedback-driven movement. The present study combined a novel kinematic assessment, detailed here on this slide, with clinical measures of limb function to assess the effectiveness of therapeutic instrumental music playing on paretic limb control. The study was a proof of concept for further validating the use of music and rhythm-based interventions for promoting functional recovery in chronic stroke. The kinematic outcomes mentioned above were used as dynamic movement assessments, while more traditional clinical assessments were applied pre- and post-interventions. The approach was expected to contribute to a more holistic understanding of motor relearning associated with music-based rehabilitation. 28 community-dwelling adults completed this study. All participants had sustained a unilateral stroke on average 66.9 months prior to participating. Participants were primarily recruited from the Greater Toronto area. Inclusion criteria was hemiparesis with at least minimal volitional control of the affected limb, as well as adequate language comprehension and neural functioning skills. Clinical assessments were obtained at 2 baselines separated by 1 week to ascertain the stability of motor function. To determine the effects of the intervention, clinical assessments were once again obtained 1 week after the conclusion of training. The clinical assessments included the Fugel-Meyer upper extremity function and the Wolf Motor Function Test functional ability scale. Briefly, the Fugel-Meyer assessment is the most commonly used post-stroke motor assessment. The assessment generally covers motor function in the upper extremities. The Wolf Motor Function Test assesses functional ability in the shoulders, elbows, wrists, and hands. An example of the assessment includes having the patient attempt to place their affected forearm onto a table by abducting at the shoulder. The ease at which participants can complete these movements is scored by a clinician. For both measures, increasing scores provide evidence for functional recovery of paretic limb movements. Participants completed 30 minutes of TIMP training 3 times per week for 3 weeks. During these training sessions, they wore a triaxial accelerometer on the paretic limb, which measured limb movements at a sampling frequency of 1000 Hertz. TIMP exercises were designed to facilitate retraining of functional movement patterns involving proximal and distal control. The main digital music devices used for mapping rhythmically cued movements were a Yamaha stage piano and DTX digital drums. At the beginning of each session, a metronome was used to ascertain the participant's preferred movement rate, and this beat was subdivided for slower tempies to facilitate rhythmic auditory entrainment. This approach provided participants with a consistent rhythmic template for gauging movement trajectories in accordance with spatial temporal constraints. Instruments and devices were positioned spatially as movement endpoints to target specific movement types, including shoulder abduction/adduction, elbow flexion and extension, wrist pronation and supination, selective finger dexterity, and upper trunk rotation. Each session was subdivided into 2 blocks of 15 minutes, in which 3 minutes were dedicated to each of the 5 exercise foci described above. During each 15-minute block, the sequence of movement foci and instrument use was changed to avoid rote repetition and maintain variety and enhance flexibility to engage in motor relearning during training. Training was further augmented via specially designed interactive sound tablet known as the Sonification Arm Training Apparatus, or Sonata for short. The Sonata consists of a tablet surface subdivided into 32 squares of geometric shapes that generate sound or rhythm when touched. Touch patterns are programmable and can be visually displayed from a controller that the clinician operates on-site or even potentially remotely. Programmable exercise patterns include coordinating wrist flexion and extension, elbow flexion and extension, shoulder abduction and adduction, and as well as trunk rotation. The velocity and force of these movements can be mapped onto a rhythmic pattern such as pitch, providing the sensory motor system with an auditory representation of one's own motions. Shown on the left of the slide is the sample acceleration data from one participant, with session 1 shown in red and session 9 shown in teal. This raw acceleration trace was converted into the frequency domain representation shown on the right side, and I'll take you through how we arrived at this frequency representation. The accelerometer data was first obtained for the 3 orthogonal cardinal axes, that is the X, Y, and Z movement axes. Given that the speed and exact movements performed during training differed across participants and sessions, resultant acceleration was chosen as the primary substrate for the frequency domain analyses. These resultants were computed as the square root of the sum of the squared value of each axis and at each time point. To reduce noise introduced by this process, the time series were low pass filtered using a second order dual pass Butterworth filter with a cutoff frequency of 40 Hz. The power spectral density estimates shown on the right of the slide were obtained from this filtered resultant time series using the p-Welch function in Python. Two main outcomes were quantified from each time series power spectral density. The first was the magnitude, or the largest peak in the spectrum, herein referred to as peak power, and shown using the green vertical line on this trace. And we also extracted the width in hertz of the largest peak in the plot at 50% of its height, herein referred to as peak width, shown by the black horizontal line. As mentioned in the introduction, peak power can be used to assess the degree of volitional control present in the reaching movement. Increases in peak power over time may suggest that the presence of improved volitional control of the paretic limb was indeed occurring. Peak width is used to assess temporal stability of voluntary action. That is, if the width of the peak covers frequency ranges associated with feedback-driven movements, such as those that typically occur beginning at 4 Hz, it may be surmised that the temporal control of paretic limb movements was improving. Unlike peak power, decreases in peak width are generally considered to reflect improved control of paretic limb from a temporal perspective. Separate ANOVAs for peak power and peak width were conducted with session, that is 1 to 9, entered as the within subjects factor. Given the continuous nature of the effective session, a polynomial trend analysis was further used to quantify changes in absolute peak and peak width across the sessions. In the presence of significant polynomial trends, pointed paired samples t-tests were used to highlight associated session-related differences. The procedure and data analysis outlined on the previous slide led to the formation of the following hypotheses. Regarding the clinical assessments, it was predicted that scores would increase for both Fugl-Meyer and Wolf motor function assessments from pre to post assessment. These improvements in the clinical assessments would likely be mirrored using the dynamic assessments of limb acceleration, wherein we would observe increases in peak power from session 1 to 9 and actual decreases in peak width from session 1 to 9. Such a pattern of effects would support the utility of music-based interventions for improving paretic limb function in chronic stroke. Shown here are the results for the clinical assessments. Initial data screening and processing determined that both the Fugl-Meyer and Wolf motor function tests did not meet the assumptions for parametric analyses. As a result, differences between pre- and post-test scores were compared using the Wilcoxon signed rank tests. Scores on each assessment are shown on the y-axis, and time is shown here on the x-axis. The analysis revealed that both assessments improved in terms of scores from the pre to post-test assessment. For the Fugl-Meyer, the median test score improved from 31.5 to 38.5, while the Wolf motor function scores improved from 31 to 39. Shown here are the results for peak power on the y-axis and session on the x-axis, and peak power was our primary dependent measure. The results of the repeated measures ANOVA for peak power revealed a main effect of session. Follow-up trend analyses further revealed significant linear and cubic trends. The relatively large linear effects suggested that patients demonstrated improved paretic limb control throughout the intervention. In addition, the presence of the cubic trend indicated that this general pattern was likely modulated by some non-linearities, although the associated effect size was substantially smaller than the reported linear effect. Given the strength of the linear trend and the hypotheses outlined above, the linear trend was further examined using a t-test to contrast differences in peak power between sessions 1 and 9. The results showed that movements of the paretic limb increased in peak power from session 1 to 9, indicating that paretic limb movements were executed with greater peak acceleration and at frequencies associated with voluntary control as time spent in the intervention increased. The results for peak width are shown on this slide. The peak width measured in Hertz is illustrated along the y-axis, and session again shown on the x-axis. The repeated measures ANOVA computed for peak width yielded a main effect of session. The polynomial trend analysis revealed the linear model as the only significant trend, indicating that paretic limb movements were executed with reduced temporal variability over the course of the intervention. Post hoc tests for the linear trend contrasted peak width between sessions 1 and 9. This analysis, however, did not reveal a significant difference between those sessions. Yet, the presence of the significant linear trend, which may have been influenced by the peak width and certainly in sessions 7 and 8, indicated that such improvements in temporal consistency may further be anticipated if additional training sessions had been provided. Overall, however, this non-significant finding remains encouraging. In summary, 28 participants completed 9 training sessions involving the provisions of anticipatory rhythmic auditory cues and sonification feedback from the Sonata tablet while executing upper limb movements during the training sessions. The results showed increases in peak power between session 1 and 9, indicating that paretic limb movements improved in speed and intensity during the intervention. Increases in peak power also coincided with overall reductions in peak width across sessions. When viewed in conjunction, both findings suggest that motor control of the paretic limb improved as a function of being in the intervention. Critically, the kinematic analysis was consistent with the clinical recovery assessments, but further provided novel insight into how TIMP-based exercises elicit specific voluntary motor control mechanisms. More specifically, TIMP training may elicit changes in limb acceleration that could not have been ascertained using clinical assessments alone. This study may be of considerable importance because motor recovery in the chronic stroke phase is often poor. However, music-based interventions create an environment where the provision of rhythmic auditory cues combined with auditory cues associated with contacting the instrument can be utilized by patients to guide paretic limb movements. More specifically, mapping functional movement execution in an interactive music production paradigm may direct motor control mechanisms towards a more intentional goal-driven motor programs. Given the evidence supporting the efficacy of music-based therapies within the chronic stroke phase and the novel finding reported here of increased intentional control of the paretic limb, post-stroke management approaches should continue to utilize approaches like TIMP to facilitate sensory motor recovery. Approaches like TIMP can also leverage powerful audio-motor pathways that may not be targeted by traditional approaches to physical therapy that rely on visual motor pathways. By stimulating the brain using music, novel pathways between healthy cortical regions may be developed, which can improve motor function in chronic stroke. Lastly, the frequency-based analysis utilized here will likely benefit future assessments of motor recovery, especially when considering mechanisms of upper limb control. The significant increase in peak power suggests the paretic limb movements were executed with greater intensity and with improved intentionality, highlighting that functional improvements in paretic limb control had occurred. Functional changes in peak width were also revealed, with evidence of peak width narrowing across the intervention, localized within frequency domains that are typical of feedback-driven movement. These kinematic outcomes were also consistent with significant pre- and post-test differences observed in our clinical assessments, suggesting that altered limb acceleration is a mechanistic change contributing to improved motor function in music-based rehabilitation. As a result, the frequency-based kinematic assessment developed here may provide a robust and objective measurement of motor recovery in chronic stroke. Such an assessment is relevant for future rehabilitation interventions that are rooted in physical therapy. Accessible and easy to use kinematic assessments represent a pathway to transform the evaluation of rehabilitation and strengthen clinical outcomes. To date, the efficacy of rehabilitation interventions in chronic stroke continue to be determined by progress on standardized assessments, including the Fugl-Meyer and Wolf motor function tests. Critically, these tests are often administered by multiple raters, which can reduce the ability to draw firm conclusions from the data based on inter-rater reliability. Objective kinematic assessments, like the ones reported here, can alleviate such limitations. This novel application also coincides with recent technological advancements that have yielded wearable accelerometers that are cheap, easy to use, and ubiquitous. If worn during rehabilitation, clinicians can employ frequency-based kinematic assessments to monitor motor outcomes on a session-to-session basis, as well as in real time, which, when employed alongside a music-based intervention, is expected to enhance patient-centered approaches to rehabilitation. Thank you for listening, and I hope that you'll also enjoy some of the other talks by our research group at ISPS.
Sorry, thank you for your talk, Tristan. Very, very nice. Does anyone have any questions they want to ask? I have a few questions myself, but if anyone else has a question they would like to ask first. Tristan, I was just curious, did you have a control group with your stroke rehab?
In this study, we didn't, unfortunately, but we've been trying to secure some extra funding to have a control group. We're really interested in obviously looking at the effects of TIMP in comparison to individuals who engage in typical physical rehabilitation. I know that in some of the RAS work conducted by Professor Tout, in Parkinson's, obviously, which is a little bit different, but I've seen studies where individuals, obviously in control conditions are employed, and RAS tends to facilitate the motor outcomes. And in addition, there's also studies where part of the experimental group will actually drop out of the intervention and then rejoin weeks later. And similar effects are observed there, wherein they actually improve once they re-enter the intervention. And this is still better than the control group. But yeah, in the future, we're looking to run some controls using TIMP versus traditional physical therapy. We have a grant in right now that's being reviewed. So hopefully maybe at the next ISPS, I can update you on the progress there.
Excellent. Clara, you have a question.
Yeah, thank you. So actually I was going to ask about the control group as well originally. And I guess there's control with different interventions, but also control with just age match control without any pathologies. Because I was wondering, I don't know how old your participants were.
I can tell you, if you just give me 1 second. I can remember off the top of my head. I believe so I know that the average time since the stroke was 66.9 months. The average age was 55.9.
Okay, because yeah, it's still pretty young, but I was wondering if you would see the same type of improvements on subjects that would not have stroke. Because for example, with gait, we see with rhythmic auditory cueing, you still can improve the rate of older adults despite any pathologies. And I guess if you had that information, compare your improvements with the PIC frequency, how it would differ from age match.
Well, I know in a lot of the data that kind of validated the use of the Sonata apparatus, that was in healthy individuals, and they perform reaching tasks, and the provision of the auditory feedback made the movements actually more consistent and more accurate as well. So I'd expect that I think that the mechanism of RAS, just that predictable rhythmic timing, can be utilized by both healthy controls as well as patients. So I would hopefully expect to see similar improvements in both healthy and stroke individuals too. Yeah, I agree. I share a lot of these concerns as well. We definitely need some control groups to further validate the use of TIMP and also this novel kinematic assessment that I detailed here.
Thank you.
Would anyone else like to ask a question or make a comment?
I have another one, if I may.
Please, yes.
I was just wondering, because you had like your participants, I think it was 60, was it month post stroke?
Yes.
That's huge. That's big. Is it like, was it like a wide range of time from stroke that you had in your sample?
Yeah, so it is like a wide range. I think the thing is we were mostly concerned with chronic stroke individuals. So after they've been, of course, discharged from the hospital, they're at home living just with this paretic limb. It's kind of odd, but the approaches to rehabilitation in Canada, at least, there isn't a lot of targeted rehabilitation focused on the chronic phase. So we were kind of really interested in trying to target these people, again, when recovery is thought to have plateaued, that can actually facilitate their ability to move. And we kind of followed up with these people just kind of very briefly, like in support of a grant application. And they were saying that some of them, of course, they responded to the emails, that should be taken with a grain of salt, but they reported that, you know, they did enjoy, of course, being in the intervention, and also they benefited over time, but we don't have any actual data to support that. So again, we'll be looking more at control groups, as well as looking at it over time to see the stability of this recovery. Because again, like especially in like the chronic phase, this is when, and even if we saw in those previous talks where they learn this kind of maladaptive movement strategy, and that's carried forward. So unfortunately, by the time that we see them, these compensatory movements and all these things are very ingrained in their actual movement patterns. So it's very difficult to actually correct these things. But it's at least something that we're trying to work on, and that's the goal of this work, is to regain this like functional motor capacity, especially for individuals in the chronic phase.
So do you think that if you did the intervention right after stroke, for example, people maybe would prevent maladaptive motor function?
I think so. I think that unfortunately, the most common approach in like acute stroke care is just repetition. So it's basically just like repeating movements like in the magnitude of thousands of repetitions. And this is typically done like in a rehabilitation setting. The issues, of course, is like related to space, clinician time, and things like that. So there really is kind of a push to get these people out into the community. So unfortunately, a new patient can come in and they can be treated because they need it. But I would expect that the earlier onset of this intervention, of course, with many different types of illness, would hopefully facilitate the regaining of motor control. So certainly that's something that we'd be interested in testing in the future.
Thanks so much.
Yeah, fantastic. Did they have a particular musical interest, any of these people? Just out of interest, sorry.
Yeah, like we didn't,
might have missed that.
Yeah, like we didn't like constrain like, okay, you have to have played a musical instrument or anything like that. In general, we kind of got people who they were musicians when they were like younger. I'd say like the majority of people had enjoyed listening to music. We took that type of data, and some of the responses to people, and some of the responses from the actual patients, they reported that they were interested in actually enrolling into the intervention because it was something new to them. So not only do they maybe not enjoy listening to music or engage in musical activities, but the thought of using music to kind of treat the paretic limb was exciting to them. So it's kind of interesting to think that even if people who aren't musicians or listen to a lot of music, they see this music-based intervention as a kind of novel approach that they might enjoy. And I think many of them did, which was good.
Great, fantastic. Peter.
Yeah, a quick question. A few years back, I was looking up the terms pacemaker and Parkinson's disease. And in the 1970s and 80s and maybe early 90s, there was several studies done where it wasn't thinking of the heart pacemaker. That's the one I was looking up, but it was having essentially a click track or some kind of other kind of purely rhythmic intervention. What's the benefit of a musical intervention where there's melody and complexity in terms of the layering of the music, compared to simply having a rhythm track that's going along? I mean, this is a really important thing as we're trying to show that music has functionality in terms of rehabilitation, etc. the term music is usually ill-defined. You know, if you do this with a Beethoven symphony, you're going to get people that are falling over. They're not improving because he's undermining the rhythmic implications of what he's doing. So when we talk about music, we overgeneralize. So I'm wondering how, if you've taken a look at some of those earlier studies that are basically rhythmic in nature and not necessarily full-blown complexity in music.
Yeah, so like many of those studies, especially in the late 80s and early 90s, were conducted by my advisor, Professor Tout. And I think that the effects of leveraging RAS, so these rhythmic auditory cues, with this instrumental music performance would be additive. So if we have these RAS models that can entrain the motor system to actually, prepare actual movements, and then if you enter that into a music production paradigm where we're using instruments as movement endpoints, not only do participants have these rhythmic auditory cues that they can use to plan movements, but when they're actually executing the movements, they're getting auditory feedback for when the movement is completed. So in the end, it creates a kind of feedback and feed forward loop that I think really facilitates the reacquisition of control of these limbs. So I'd say that if we can leverage RAS together with instrumental music playing, I think that that's kind of the direction to go in this research area.
Great. Well, thank you very, very much to all our presenters. I'd like to give you all a hand for a lot of wonderful presentations and thought-provoking work today. It's time now for you to go to your break. I think you have your Kumo space where you can, I don't know, sidle up to each other in the disco and have a conversation, as far as I could work out yesterday. There's all sorts of interesting things you can do in Kumo space. And then the next presentation is in half an hour. I think Christy Guptill, you are there. You are presenting in half an hour as well, I think. So you have half an hour break. Thank you for coming, and thank you again to all our wonderful presenters.